So we're just going to let people in as they're arriving. You know what it's like. Everyone's had a spot of lunch and looked at the time and realised they need to get back on. Yes, the usual etiquette, please. If you could pop your name and organisation in the chat, that would be very, very helpful because it gives our presenters and speakers an idea of who is here. And that does actually matter more than ever because there's an opportunity to get involved in the next phase of research. So it's helpful for our Nuffield colleagues. Good. Oh, thank you. Everybody's being very, very obedient. Oh, and there's lots of things from Annie giving us the lowdown. Just letting a few more folks in. You'll be glad to see we're all on brand with our Care Provider Alliance logos, those of us representing the CPA. I know you're used to seeing me with my NCF logo, but today it's all about doing it together. Okay. So, oh, I was just about to get going then. Let's get a few more people in, last people. So, hopefully you're expecting to be at this webinar. So this is one of the Learning Network webinars that the Care Provider Alliance do in partnership. And today we are working with the Nuffield Trust. They came to talk to us a little while ago about some very, very interesting research they've been doing around continuing healthcare. And so we thought it would be really useful for them to share it more widely, because certainly I know across NCF membership, this is an area fraught with difficulty. Ooh, can you go on mute, please? Thank you. This is an area fraught with difficulty for both people, families and care providers. And we saw, didn't we, from the ADAS survey earlier in the year, just what a set of inequalities there are across the country. So some etiquette, please go on mute. Please do use the chat function for questions. We do have the ability to bring you on camera, so when we get to that point around Q&A and further discussion, if you want to come on camera and actually ask things in real person, you can stick your hand up and we'll try and get you on. We are recording the session. The recording and the slides will be made available, as will a transcript. I haven't checked the etiquette around AI note takers. If we've got any on the call, please don't email everybody everything with every comment that they made and their name against it. Please set your systems up differently. And oh yeah, I'm Liz. I'm the policy director at the National Care Forum. We're one of the organisations in the Care Provider Alliance, and I am now going to hand over to my colleagues at Nuffield to say hello and get us going. Thank you. And thank you to everyone for coming.
Hi, thanks very much, Liz. Hello, everyone. My name's Rachel. I'm a fellow at the Nuffield Trust, and I'm really pleased to be joined by my colleagues, Becky Best, Emma Dodsworth, Miranda Davis, and Natasha Curry, who are on the call with me as well. Thank you very much to the Care Provider Alliance for giving us this opportunity to share a bit more about the work that we're doing on continuing healthcare, and yeah, thank you all for coming along today. So just to give you a little bit of background in case you're not familiar with the Nuffield Trust, so we're an independent health and social care policy and research organisation. We conduct research into lots of different topics across health and social care, and here today to talk a bit more about the work we've been doing on continuing healthcare specifically. So just to give you a bit of a summary of what we're going to cover today, and I'm hoping you can see the second slide. So we're going to start by giving you a bit of an overview of the work that we've done so far.
Sorry, Rachel, it's not moved on for me.
Oh, has it not? Oh, okay. Valeria, perhaps you might need to step in and move the slides along if that's okay.
Bingo, I can see the second slide now.
Okay, I can't, so that's a bit confusing, but okay, I'll just try and move that along at the same time. Great, so hope you can see an overview of what we'll cover today. So a bit about the work we've done so far. As part of that, we're going to talk about what national data shows about what's been happening to CHC assessments and eligibility over time. I'm going to talk a bit more about the work that we're doing now and the next steps, and in particular how you can get involved in our work. And finally, we'd like to open it out to questions and have a bit of a discussion as well. So next slide, please. Great. So to start with, I'm going to give you a bit of an overview of what we've done so far. So we've done quite a lot of work in social care more generally, for example, looking internationally, some work on the provider market. And we started looking at NHS continuing healthcare early last year. And what that's involved is speaking to stakeholders from across health and social care to understand a bit more about the issues and their experience. We've also looked at previous reports and investigations. So, for example, the National Audit Office report from a few years ago and reports by the Parliamentary and Health Service Ombudsman as well. And alongside that, we've conducted analysis of data which is published quarterly by NHS England, which measures a number of things such as the number of assessments, numbers of people eligible, and delays as well. So this culminated in an explainer which was published on our website in June, and I can share a link to that in the chat and after the webinar, which essentially sets out at quite a high level what the CHC process is or should be, what the data analysis showed in terms of some of those high level trends, and also some of the key issues we've heard about through the conversations that we've had. And I should just say that our work is looking at England and people over 18 only at the moment. So that's the scope of this current piece of work. Next slide, please. So what has been happening to CHC assessments and eligibility over time? So what I'm going to do now is talk you through some of the key findings from that analysis. So next slide, please. Okay, great. So the first thing that we wanted to highlight, which we've been looking at, is that the overall number of people being assessed as eligible for CHC is actually falling over time, and that's the grey line that you can see on the chart. Now, obviously, people are continually being assessed. Some may no longer require care or become ineligible, so that overall number changes constantly. But as of the end of March this year, the total number of people eligible for CHC was just over 52,000, and that was made up of just over 34,000 eligible for standard CHC and just over 18,000 eligible for fast track CHC. We know that the assessment conversion rate for standard CHC in particular has changed over time. So that's the proportion of people who have undergone an assessment and then found eligible. And we've seen that's actually fallen from 27% to 21% since mid-2017. So essentially that means that by early this year, about 1 in 5 people who were undergoing assessment were found eligible for a standard CHC care package or for funding. Next slide, please. But what we can see within that is that an increasing proportion of people eligible are eligible for fast track continuing healthcare rather than for standard. And these big drops on this graph here are for the COVID pandemic. And obviously that's for people whose condition is rapidly deteriorating. So even though at an overall level, we're seeing that numbers of people eligible is going down, within that actually of those people eligible, more of that is for fast track CHC rather than standard. Next slide, please. So what I've just been talking about is at a national level, but actually when you look at what's happening at an ICB level, you can see that the numbers of people eligible varies hugely across the country. and that's the same for the assessment conversion rate as well. So you can see here that if you look at the numbers per 50,000 of the population, there's a huge range from 36.9 in Cornwall up to just over 300 in Lincolnshire. And similarly, the assessment conversion rate is also widely variable. So looking at just over a fifth at a national level, as I just mentioned, but within that, there's a huge range. So from 7.3% in Gloucestershire to 42.5% in Leicester and Leicestershire and Rutland. So obviously, we know that variation is not a new issue, and that's been something that's been consistently highlighted in previous reports and investigations. And we also know that there are several reasons for this, but I think it's quite clear to see that that variation is quite stark when you look at it at those levels. Next slide, please. Great, thank you. We also know that people are waiting longer than they should to hear the outcome of their assessment. So there's guidance in the framework which states that people should know about it within 28 days. But actually, we can see from looking at the data that there can be delays. And as of the end of March this year, you've got just 1,730 referrals which were incomplete and delayed by longer than 28 days. And within that, there's people who are being delayed by over 26 weeks, so quite a significant amount. Although the delays, reasons for those delays are not recorded, we know that there's a variety of reasons. Could be to do with disputes and backlogs in assessments and staffing pressures. But it's clear that there are obviously people who are waiting much longer than they should be to hear about the outcome of their assessment. Next slide, please. So while these trends help to paint a broad picture of what's happening with CHC at a national level, we know that it doesn't tell the full story and that there are limitations to what the data can tell us. So just to highlight a few examples, firstly, it's based on the date of eligibility rather than when people actually started receiving funding or care package being put in place. So it's difficult to know how long it takes for that to happen. The current data set doesn't include information such as person's age, gender or ethnicity, although the patient level data set, which is currently being rolled out, should be more comprehensive and fill in some of those gaps and also include information about people under 18. And finally, on delays, those figures are based on ongoing activity, so it's quite difficult to tell which proportion of overall referrals and assessments this represents. Next slide, please. And just to give you another example of what the data can't tell us and why it's really important to hear from people kind of working on the ground about what's actually going on. One of the things we've also been looking at is the data on numbers of people no longer eligible for CHC. But we know that at a high level, that includes people who have died or been found ineligible following reassessment. So while we know that the overall conversion rate, assessment conversion rate is going down, we might expect that an increase, there's more people being found no longer eligible. So that suggests that this isn't telling the full story, and it's really important to kind of understand a bit more about what's happening to hear what people's experience is. Next slide, please. So I mentioned when we did this work that as well as looking at that data, we also had conversations with several stakeholders, and this was really helpful for us to kind of understand a bit more about what's going on. And I'm sure that some of these issues will be familiar to you, and as I say, some of them are very long-standing. So we know that it's a very challenging process for individuals and families. It's extremely complex. There's often lack of awareness about CHC. And then challenges once people actually get to the assessment stage as well. We know that there's concerns that some people are less likely to be found eligible, so perhaps people with particular health conditions, or to even know about it in the first place. So there's a real concern that people who could be eligible for CHC are not able to access it. We know that it's a really important area for collaboration between the NHS and local government, but like other areas, this is very dependent on relationships. And we know that there are significant challenges around the wider context in funding, and also wider challenges with integration as well. So it can make that particularly challenging. I think what's really clear and has come through from all of the conversations is that there's a really stark divide between if somebody's eligible or not, and the consequence that that has on funding for their care. We know that CHC is based on having a primary health need, but that's obviously quite arbitrary, and there's a lot of grey areas. We also know that more generally, health needs and care are getting more complex, and we might expect that to be reflected in the numbers of people being found eligible. So it's clearly important to understand a bit more about what's going on. And Liz has already mentioned the ADAS survey, but we know from some of the findings in that actually there is obviously a lot of other challenges with CHC. So a lot of people reporting that the numbers of people qualifying is decreasing in their area, that there's been an increase in people being found no longer eligible, and also that there's been an increase in disputes as well. So there's clearly a lot of challenges with the current system at the moment. Next slide, please. So that's where we got to, and that's what we published back in June. But through those conversations and all of that work, we really felt that this was an area we needed to go into a bit more depth on to try and understand a bit more about what's behind those numbers. And particularly, we're really interested in understanding more about what's driving variation and issues around inequalities. And those were two big issues that came through in the work that we had done. So what we're doing now is a project which is part funded by the Nuffield Foundation, which is aiming to explore inequalities and variation in more detail. In particular, we want to understand more about what's driving variation, particularly in terms of the numbers of people eligible, but also the assessment conversion rate. What we can understand about the relationship between eligibility for CHC and other patient and local area characteristics, such as demographic information, but also deprivation, and understand a bit more about what, if any, action local systems are taking to address this variation. So this is a mixed methods project, which will involve freedom of information requests to NHS England and to integrated care boards, interviews with people working within integrated care boards, and focus groups with care providers, which I'll touch on a bit more in a minute. And finally, looking into more local data to understand a bit more about what's going on with these issues. So next slide, please. So what we would like from you, and to share a bit more about how, if you're interested, you can participate in this work. So one of the things I mentioned is that we're going to be holding some online focus group discussions, and we're really keen to hear more about perspectives and experience of care providers in relation to CHC. And we'll share more information about how you can take part after the webinar. But just as a quick summary, what we really want to understand is a bit more about your experience around how CHC is assessed and funded, and how care is commissioned for the people that you support. We'd like to hear a bit more about the challenges that you're experiencing, but also areas of good practice and what action is required to address these challenges. So we know from talking to Liz and also others that this is a huge issue for people across the health and care system, but especially within care providers. And we really want our work to kind of reflect that experience. And as I said, we'll share a bit more about how you can get involved in that after the webinar. Next slide, please. So before we get into the discussion, I just want to pause here to see if anybody's got any particular questions, either on what we've shared so far in terms of those findings, or anything around the work that we're doing. And we're going to move into a bit more of a discussion in a minute, so we might cover some of that then. But yeah, any particular or initial questions, very happy to take them or pop them in the chat.
While people are thinking, I was wondering whether you, from the first phase, do you get a sense of whether these massive inequalities are kind of by accident or by design, if you see what I mean. You know, is it that local systems are doing everything they can to save money, and this is just a kind of casualty of that, or do you think that there are kind of informal policies to try and restrict spending on continuing healthcare? Got any sense of that at all?
I mean, I think that's something that we're really hoping to unpick a lot more in this more in-depth work. I think in that first stage, as I say, we had some initial conversations and we looked at the data at a high level. And I think there's a number of different hypotheses for why that could be, or what could explain that variation. I think some of it's warranted, so it's probably down to the population needs, so whether there's a higher proportion of older people, for example, so things like that. We know that it can also be affected by things like the existence of certain services and how kind of consistent they are about referring people for CHC in the first place. So I think there's a number of reasons, there's a number of explanations on that side. But at the same time, we know from the conversations we've had, but from other work, that the financial context is very, very challenging at the moment. And there's definitely a perception that that is going to be driving decisions, and an anxiety that that's something that's being used to drive decisions, which is obviously not what should be happening. But we're hoping that that's what we can kind of explore a bit more in this next phase of work.
Okay. Oh, I see Miranda's answered Mark's question. Just interested, Mark, what's prompted that thought? Are you interested in drilling down into the inequalities in more detail? See if Mark
I think it's really helpful to see that comparison by area, even if those areas are quite geographically close together. So we're particularly obviously interested in around Greater Manchester.
And does it go down to local authority area, Rachel and Becky, or is it ICS area?
I think it's ICB and then sub-ICB.
ICB, okay.
So obviously previously it was at CCG level. Okay. Now you've got ICB and sub-ICB.
Okay. Are you able? Okay, got a question about how the relationship between the ICB and the local authority here. I wonder. So is that? Okay.
We have had some fun and games trying to sort of map the data. I don't
Yeah.
know if Emma wants to come in and say more, but it is, yeah, it's not straightforward.
Yes, it's exactly a problem we've been trying to solve, and it's just really interesting because obviously you like Rachel mentioned, it's CHC is the kind of bridge between the NHS and local authorities, and yet all the data is disaggregated at NHS geographical boundaries, and so making that link and looking at the data across like social care, for example, which is organised at local authority, can be really challenging. But the ONS does have lookup codes where you can combine the two geographical areas, but yeah.
Well, it's interesting, isn't it? So, by the by, when we were up at the Labour Party conference last week before, whatever week it was, and we were hearing constantly, in a good way, I think, from the Secretary of State and for Health and Social Care and from the Minister, their focus on their 3 shifts of hospital to community, sickness to prevention, analog to digital. I mean, they have clearly got some quite big ambitions for how to make sure that we're all working in a way that delivers maximum benefit to people in local systems and the best outcomes. And clearly, a successful continuing healthcare system basically provides healthcare out of the very pressured acute settings. Now, if there are perverse incentives between our integrated systems and our local authorities, which mean that there's more pressure on local authorities around social care, and there's less support from continuing healthcare, and that's driving pressure locally at the front door of hospitals, it would seem this would be an area they'd be terribly interested in, alongside the Better Care Fund working well. So just, you know, it's interesting, isn't it, that this is not well understood. I was going to say, I think we've got some dasses on. That's a good question. Good question from Michael. Have you done any analysis about the interrelationship in local areas between continuing healthcare and funded nursing care? That is a really good question.
Yeah, that's a really good question. And actually, that is part of the work that we're currently doing. So we haven't published it in the work we've done so far, but it is something that we're doing as part of this ongoing work. So Emma, I don't know if you want to come in now or say anything about that, but that will be part of this, yeah.
Yeah, it definitely will be. And we're hoping to bring in some sort of finance and expenditure data to sort of test the hypothesis of whether there's been cost shifting and the types of care that are being provided. If funded nursing care is cheaper than CHC, have we seen a sort of rise in that compared to standard and fast track CHC? But yeah, it's all in the works. But yeah, it's a very important question that we want to address.
Yeah, absolutely. Thanks, Emma. Any other questions? Otherwise, I don't know if we want to move on to the discussion point. Liz, I don't know if you had any other particular questions at this point.
Well, I've got a sort of fundamental question, but that's probably something you want to look at in your next phase of research, which is it's not working. And, you know, actually, there's a lot of healthcare going on in nursing settings that is, you know, good for people because they're being cared for out of hospital, but it's not really being funded properly. And, you know, actually, we probably need more of it, not less, but we're getting less of it and very variable. There's a kind of fundamental design problem, isn't there? So anyway, I'll stop because I'm probably preempting your next ask of our participants.
Thank you. Yeah, I think that's really at the heart of a lot of this work, really, that kind of question. Thank you. So I'm going to hand over to Becky now, who's going to lead. We've just got a couple of discussion questions. I guess one thing to just say is we're hoping that the focus groups will allow a much greater in-depth discussion of some of these issues. So we're not going to kind of report on this particular conversation here in our report, but we're really interested to get your kind of initial reflection. So Becky, can I hand over to you at this point?
Of course. Thanks so much, Rachel. Yeah, if you could go on to the next slide, please, Valeria, that would be great. And what we'd really like is, as Rachel said, that, you know, the data only tells us so much, you know, and we really want to hear more about your experiences actually working in this area. So kind of thinking along what Rachel said, you know, we've got the focus group where we can talk, you know, we'd really like to hear much more about your experience in detail, but is there anything that we've shared so far that resonates with your own experience, or is there anything that surprises you that you feel like just doesn't reflect what you've been experiencing at all? And perhaps if you wouldn't mind stopping sharing the slides, Valeria, for now, and then we can kind of have a little bit of a conversation. I've put the questions in the chat there. And please feel free, put up your hand, join in the discussion, share your experiences, or if you'd prefer, put something in the chat. But yeah, we'd really like to hear anything that's resonated with you or not resonated with you.
So
or anything. Sorry, go on, Liz.
Well, I was going to say, whilst folks are gathering their thoughts, I'm just having a look at the folks on the call who I know their organisation. So you've got quite a spread of area, really, but you've also got people who've got a national perspective. So, not wanting to put anybody on the spot, but I'm kind of interested in people that operate across a particular area and then also operate a bit more widely. So let's go more widely. John from MenCap, you're on here. Just from a perspective of providing in lots of different areas. Is there any insights you'd want to bring? If you're happy to come on, of course. See if he is happy.
Oh,
I don't know. I've lost him now. I'm moving around my screens.
Mark, you've kindly turned on your camera. Have you got something that you'd like to share while we wait for John?
Yeah, I'm really interested in the conversation around CHC funding. It's been something that's been on my agenda list for many years, really, and I suppose this year particularly, there doesn't seem to have been any conversation in Greater Manchester that I can spot regarding what the fee rate should be and how it should be commissioned. I don't think there's been any discussion with providers. So, coming from a slightly different angle, I think conversations are still free. So it would have been great to engage with the ICBs on this issue around what they hope to commission. And then there's the inequalities across Greater Manchester. I can only really speak for GM and our experience, but in terms of the price differentials and the habit of setting CHC funding at the same level of local authority contract price for nursing care plus FNC. So people's complexity of need increases. And if they're paying privately for their care, the amount of money that a provider receives goes down. So it's the worry about that is the impact on availability for those people who need care the most, because I think it exposes providers to much greater risk that they're going to be left holding significant financial costs, which the NHS sort of exonerates itself from. So I'm really interested in the debate, and I try not to let my cynicism and bitterness impede the conversation too much, because I think it's an area that does need exploring in terms of equality of access. And I'm interested. There was a stat before about sort of outcomes, and I'm interested in whether some of that data could be matched against length of time in hospital with no right to reside. I think that there's interesting data to be explored there, really.
Thank you, Mark. There's so much interesting stuff there, and I think that's such an important point, isn't it? And yeah, as Liz, you were saying before we moved on to this too, like that kind of the value of community care is really being recognised at the moment. I think there's such an opportunity here for that to be kind of highlighted. I wonder if anyone else has any thoughts on the kind of commissioning kind of interrelationships or collaboration on that, like you were mentioning, Mark, or anything else anybody's kind of wants to say after being prompted by Mark's thoughts. And thank you also for engaging with this, because like you said, it must be really hard when there's it's a really challenging area to kind of want to kind of keep pushing on. Andreas.
Hi all. Just very briefly, kind of from working at PHSO and I guess looking at things from a complaints perspective, I think for me, kind of the main thing that's kind of really interesting and very problematic is how little analysis seems to be published, and it kind of puts it to question how much actual analysis is happening and we don't know about, or whether what kind of level of analysis is actually happening and whether that's happening at all. And the second point is that from a complaints perspective, kind of in relation to CHC, but like all other complaints we've said, it's really important that ICBs share learning. And that was going to be one of those things that was going to happen because we were moving from CCGs to ICBs. But obviously, if you're not analyzing what's happening, and if you're not making the links between all the different areas that people have talked about here, then there is a sense where nothing can actually improve because no one has a clear picture of what is actually going wrong. Or not being done very well, and this is where kind of research from places like the Nuffield Trust can make so much difference to what we know, and as kind of needing improvement on a national level rather than just individual pockets. It's not even at local level for one ICB or sub ICB. It's kind of, it feels like it's different pockets of providers and different pockets of the same area who might know what's going not so well with their service, but then that isn't shared, and then that isn't shared even more widely at a national level.
Yeah, that's so interesting and so important, Andreas. Thank you. And yeah, it takes a lot of time and effort, doesn't it, to collect data and share it, and then if it's not being used helpfully, I think that's such a good point. Thank you. Helen.
Hi there. I thought I'd come in after Andreas, my colleague there. So I'm one of the CHC operations leads at PHSO. And actually what Andreas was saying there really resonates with me about I mean, there's a lot that goes really well in CHC. Our window on it is the individual complaints that come to us. So actually, first of all, just listening to something like this, which looks at it in a much more broad perspective, is really interesting, because like I say, we're looking at individuals, just individual cases in the whole part. Andreas works in our insight team, so he does a broader look at things, whereas I work with the caseworkers and we're looking at the individual cases. So it's kind of doing a bit of everything. But we get some really great outcomes on individual complaints with individual ICBs and sometimes NHS England as well. And you think, sometimes we think, gosh, if all ICBs knew about that, then maybe it could stop some complaints happening. But as Andreas said, it's that sharing of learning that is difficult. It's not impossible. It's just like, what's the process to do that? Because it's sometimes it's even just very small things that can make quite a big difference, and we spend quite a lot of time working with an individual ICB on that, and then you think, but how many ICBs are there? And if that could just be shared, then there's going to be a huge benefit of that. So it's really just building on what Andreas said there, but if there is something potentially that's could come out of this further research sounds brilliant. I mean, these figures that we've seen, and I think who was it who asked about the data, and I was just perusing that that link that Miranda sent through there and thinking, gosh, aren't there massive differences in that? Potentially there could be some useful information for us in terms of, if we know that a complaint is coming from a particular area where, say, the conversion rate is low, then, would that make us look at it in a slightly different way? Maybe it should, maybe it shouldn't, but it would just be really useful information to sort of support what we're doing, to have it as context, to understand if there are any issues, and to also identify anything that comes out of complaints that come to us, any themes as well. So it's all a bit sort of, it's all going around my head now, thinking, oh, how could we use this? How could what we do help with that, and all that sort of stuff. But yeah, it's looking good, and I'll really be interested to keep an eye and an ear out for what's going to come out of this further research. Thank you.
Thank you so much, Helen. And it's really nice to hear about some of, the positive work that's going on, but also, such a good point about sharing learning, so that, that's such a key thing, isn't it? In every area is, how do we all learn from each other and have that openness? Thank you. And I can see in the chat, Michael, thank you. So on Andreas's point, you said there's lots of instances whereby ICBs are paying external organisations to undertake case reviews over a short period of time. Local authorities do not have the staff to be present at all of these meetings, which in itself is problematic and means there's not necessarily a balanced discussion about an individual's ongoing eligibility. That's really interesting. Thank you, Michael. I don't know if you or anybody else. Sorry, go on, Liz.
Well, I thought that was very interesting, and you kind of wonder why ICBs are therefore paying other people to undertake case reviews when they could actually potentially pay their local authority colleagues. Michael, just want to say a bit more about that, because that strikes me as an absolute example of difficult silo working that's really, potentially mitigating against the best interests of the people that we're trying to support. Have you got any more insights?
I mean, the insight is, and it's been mentioned on here before, it's pitched as one thing, but it's essentially financially driven to meet deficits by a certain period in time, isn't it? So we all know that the need for ICBs and NHS more broadly to save money, and it's kind of driven up by that to a large extent, I think. And then, the kind of a hidden one that we're hearing more about is kind of the joint funding as well, which is there's no kind of data collections around that. There's very little kind of legal protection around that. So again, NHS colleagues in some areas have dropped the joint funding as well. So it's just pushing, and you see it also, as you referenced earlier, Liz, that in the kind of ADAS survey findings, you'll also see that some local authorities are struggling with kind of increased security of need, which is kind of a general point, but actually part of that is also kind of that shunt from people that were on CHC, who obviously got very complex needs, into the responsibility of local authority care and support. So, we got asked a question by the Department of Health and Social Care is, why aren't local authorities able to manage the cost of care and kind of care packages better? But actually, if people are getting shunted from CHC into local authority care, then you didn't know they were going to come into your care, and they've historically been looked after under the guise of CHC, then you wouldn't have budgeted for that or planned for that. So it's shifting sands, but it's public money, and actually local authorities manage public money quite well, and they don't obviously have to deliver a legally balanced budget year on year, whereas NHS obviously, we know that kind of their deficits and they can overspend. So yeah, I think government are kind of sitting on the fence on it. I think they're quite comfortable. Is people are being looked after and cared for, and it's within the guise of public money.
Yeah,
so it's a difficult
and everyone's
conversation.
Passing the buck, really.
Yeah,
is what I'm hearing. So
yes, so there's quite a lot of movement around the system, but it's not the same in every area. So what we all want ultimately is a consistent application of CHC, so everyone knows, regardless of where they live, what they're going to get, what they're entitled to, and all those kind of things. The same, and everyone can plan in the same way. NHS, local authorities, providers, you all know what the kind of the system is, but we haven't got that. I was going to ask quickly, whilst I've got the floor, just around, did you do any modelling against kind of the indices of multiple deprivation or anything around that within kind of what you're doing? Either in the report or the next stage, just to kind of see if there's any kind of matches between those two things. I see people nodding, so I'm assuming that means yes.
Yeah, no, it's a really good question, and that's something that we're kind of looking at what we can do at the moment, because that's such an important point, isn't it? Considering what might be behind the data. I don't know, Emma, if you want to say a little bit more on that at the moment.
Yeah, I think it's a really good point, and it's something that we really do want to explore. I think it's important to note that the actual CHC data, the quality of it is not necessarily the best, and also it's aggregate, so it's not like we could tell. It's kind of like exploring it's not kind of concluding what the drivers of variation actually are quantitatively. That's why the focus groups are so important, and getting that contextual information, but it would be to sort of map to see if there's a pattern that emerges will no doubt be really helpful. So yeah, but definitely that is something we're exploring in this phase.
Thank you, Michael.
Thank you. Thanks, Michael. Oh, Rachel, sorry, I was going to ask you a question.
I was just going to say, just in response to that as well, it's absolutely a huge issue, and I think something that's come through the conversations we've had so far is there is a real concern that actually there are people who are less likely to know about CHC or be able to access it from different socioeconomic backgrounds. And I think there is a real anxiety about that, but it is quite challenging to kind of state that given what Emma said about the data, but it's definitely something that's kind of been expressed sort of anecdotally as a concern, and sort of particularly just for people who can kind of advocate, know about the system, that they're more likely to kind of know about it in the first place and then kind of push for it. So it's definitely something that's come through as concerning, and hope we'll be able to at least sort of explore a bit more about what the data could tell us on that.
Thanks, Rachel. Liz, did you want to come in on that point before move to Andreas?
It was a slightly different point, but I did it. It's following on the Michael's point. I mean, as he says, it's all public money. So I am quite interested in the idea that a bit of the state is paying somebody with public money to find a way of stopping the state paying for entitlements for people who should be funded by the state, which is basically what ICB's commissioning external organisations to ration their provision of CHC is doing. So it's public money finding a way to spend public money differently, quite possibly badly, actually, or certainly less fairly. So I'm quite interested in whether the next phase of the research could actually explore some of that. If that is happening, that doesn't seem to me to be a very good use of public money, particularly, again, when Michael says, you know, local authorities are under budgetary pressure every single year for a balanced budget, and yet our NHS colleagues have less pressure to do that. So it might make you a bit more liberal with your public money to save public money somewhere else badly. That was all.
No, really, really good point. Thanks, Liz. Andreas.
Thank you. Just very quickly, I was going to say on the point about people not being aware that they might be entitled to CHC or not being aware of what CHC is. That's that's a trend that kind of comes in line with a more general point about having access to the public purse. So there's research from Policy in Practice that gets published every year and shows, it showed that last year 24 billion in social welfare benefits when unclaimed. The primary reason for that is because people don't know that it exists. And obviously it's more of a PHSO perspective to look at all of that from kind of higher up the ground. But it's actually just a trend of the public not knowing what they're entitled to or not being told what they're entitled to and therefore never requesting it, which kind of seems to be across the board when it comes to public money.
That's, yeah, so interesting, all these different dynamics and that lack of a big picture. Yeah, thank you. Really interesting. Anybody else want to kind of say anything or come in?
Just one other observation, really, about members' experience of CHC, which is, well, and this is true actually for quite a lot of commissioned care, is that if the quality of care and support and treatment that people are getting actually means that their conditions improve a little bit or don't deteriorate as badly or as quickly as you might expect, you're then in a different battle about continuing healthcare, because the assessment process then kicks in again, and the fact that you have probably devoted more than you were getting paid in terms of costs to somebody's care and treatment, and actually to maintain that level of well-being and good health or less bad health, you need to maintain that level of care, but the objective assessment is that somebody's got a bit better. You're into a different ballgame of battle, but it still doesn't have a good impact for the person because we're trying to maintain that person's level of well-being that you've managed to stabilize. So
yeah, no, really, really important point. And thank you, Andreas, for sharing that in the chat as well.
So I guess, yeah. Has anybody got any other points they want to make? Any other perspectives from different parts of the country? We've got some Norfolk folks, we've got some Midlandsy folks, we've got some national folks. So any other perspectives before we try and recruit you? We've had the Greater Manchester. Mark's looking like he might want to be recruited.
We want to recruit you.
He's looking like he's up for it.
Oh, Helen, thank you. The difference with CHC compared to some benefits is that individuals shouldn't need to have to ask for an assessment. Then there's the question of whether the local processes are robust enough to capture everyone who does need an assessment. Yeah, that's such an interesting point, isn't it? Something we've heard quite a bit about. Has anybody got any specific examples of that they want to share? Or Helen, would you like to say any more about it? Yeah, please.
Yeah, I'll just come in. It just so happens that there is a case that I was looking at. Obviously, I'm not going to give a huge amount of details here, but it's somebody who didn't have an assessment for 6 years. Somebody who was living in a care home, and retrospectively they were found eligible for some funding. And it's just, that's one of the things that, you know, we know people don't understand the process. It's quite often complainants will come to us and we are at the very end of the process, So in terms of an eligibility decision, a CHC eligibility decision, they'll have had the original assessment, gone through the local appeal, gone through the NHS England appeal, and then come to us. And sometimes when we explain to them, we'd sort of explain how we look at the complaint, what have you, they're still not understanding the process because it's really complicated. But it's just that point of sort of saying, we know, as Andrea said, you know, lots and lots of unclaimed benefits and what have you, but and a lot of benefits rely on the person knowing that they may be eligible for it and then going for it. But actually, CHC, whilst people can ask, and they do, and then they get assessments if that's appropriate, but they shouldn't need to have to ask. There should be those local processes, and just having had a case recently where that didn't happen, and then it's taken years to sort out to get to the point where and of course by then you're quite often talking, you know, the individual themselves is no longer with us, and you're talking about reimbursing care, but actually having the care in the first places would be far better. So yeah, it's just, I just wanted to sort of flag that up, that, you know, in an ideal world, and we are not in an ideal world, I know that, nobody would have to even know about CHC. Obviously it's better if they do, but the whole of the kind of the group of people that are involved in that person's care should be able to sort of start that process off. It doesn't always happen though, we know that, and of course there are processes for where it doesn't happen. There is the PUPOP policy, for example, to guide people through that. So but yeah, I just wanted to make that point, that while people don't know, they don't necessarily need to know.
Thank you, Helen. Okay. So unless anybody else has any other points they'd like to make, it sounds as though, hand back over to Rachel.
Thank you very much, Becky, and yeah, thank you everybody for sharing your reflections and for your comments in the chat as well. It's really helpful for us as we kind of go along with this project to make sure that we're kind of picking up on all of these issues, so thank you. I think that's kind of the end of the presentation, so really just to reiterate that we would be really, really keen for people to get involved in a focus group discussion or get in touch with us directly if for whatever reason you're not able to attend or you want to speak to us. I think we've got a slide, if it's easy to share again, which sort of just has some links to our website and my contact details, but we'll be sharing all of that after the webinar as well. Yeah, I think that's it for the presentation. Liz, I don't know if you want to say anything in closing, but yeah, just thank you.
Yeah, well, just to say, I think, you know, if this is a real opportunity. I mean, we're with my NCF hat on, we're quite passionate about the involvement of social care providers in research that is meeting kind of key priorities for them. and that is that will bring them insights that really help their day-to-day operations as well as their longer term strategic planning. And when we were talking to Rachel and Becky and Tasha about this work that they were doing already, we thought, well, the fact that there's an opportunity for members and our wider colleagues across the Care Provider Alliance to get involved in something which we know is such a hot topic and has such an impact. I mean, it really has an impact on people, on their families, on our workforce. The amount of time our nurses and care leaders spend advocating for and trying to get continuing healthcare for the people they support is probably quite scandalous, really. So we were really pleased to be able to offer the opportunity out. If you think that there's anybody else who might be keen to get involved and be part of the focus group, do share fair or wide. I think you're open to offers, aren't you? Yeah. I can see open to offers.
Yeah, absolutely.
I just think
Lovely.
I know there's lots of issues. I know we're firefighting on lots of fronts, but this is a great opportunity. And we know that colleagues at Nuffield Trust will do a really great piece of work, which we can then use the findings of to influence the conversation with the new government. And I do think there are opportunities with the new government as well. So just really pleased that you all could come, and great thanks to our colleagues at Nuffield and also to the gang at the Care Provider Alliance who actually make the magic happen, because the magic is quite hard to make happen seamlessly. So pop in the chat if you're keen. I see Lisa's already keen. And the link is there. Get involved, have your say, share your experience, influence the future. Well, hopefully. Okay. Yeah, Mark's up for it as well. If you got the link, don't forget to take the link. We'll be sharing the slides and the recording. So if you've not taken a copy of the link, it will come to you. So yeah, thank you everybody. Great session, really helpful. Thank you for coming along. And have a good rest of the afternoon.
Yeah, thanks everyone.
Yeah, thank you so much.
Bye.
Thank you. Thanks.
Bye.